So coming to the next topic in the presentation, okay, it's about heat stroke, burns, carbon monoxide toxicity, heat stroke. All of these can be your small questions, okay. And questions can be a tricky one if you have not studied. Okay, you'll be able to answer something, but focused answering is what necessary. Okay, so to understand what stroke, first you need to understand a few basic definitions like fever. Okay, so fever, as we all know, is temperature elevation due to activity of the hypothalamus in response to some sort of an inflammation, released cytokines, and then they cause all these changes. Okay, so it can be infective or it can be a sterile inflammation also. Hyperthermia is a condition which is due to uncontrolled heat generation. Okay, so this can be because of muscular hyperactivity, etc. Okay, so what is heat stroke? Okay, there is Japanese acute medicine classification, or Buchama's definition for heat stroke. Okay, heat stroke is a disease caused by imbalance of heat generation versus heat clearance from the body without an primary underlying cause. Okay, the patient was absolutely normal. Okay, suddenly there will be a overproduction of heat wherein the body is unable to clear out that heat and the heat gets retained in the body. This imbalance between generation and clearance causes systemic issues, which is called as heat stroke. Okay, I'm repeating myself. It is a disease caused by an imbalance because of heat generation versus heat clearance from the body with a person without a primary underlying cause. How do we define it? Okay, clinically, it is defined based on temperature usually being more than 40 degrees Celsius or 104 Fahrenheit, presence of neurological manifestations like seizure, altered mental status, imbalance, or it can be caused primarily because of in the background of exertion or exposure. Okay, A, B will happen in the presence of C. Okay, so I told you earlier, Buchama's definition is what I discussed with you. There is another definition, that is your Japanese Association of Acute Medicine and Heat Stroke working group criteria. Okay, basically there should be firstly an exposure. Okay, it is an acute event associated with some sort of increased muscular activity or exposure to heat. There's increased production, decreased clearance. Temperature of the body will be usually more than 40 degrees Celsius, okay, or 104 Fahrenheit, causing some sort of a CNS abnormality majorly, which is seizures, confusion, or probably imbalance. What Japanese system involved is other systems. Okay, here Buchama took only central nervous system, but they said that there might be acute kidney injury or DIC, which can also be present because of either hepatic or renal impairment present due to increased temperature. Okay, so this is about the definition for heat stroke. Okay, if you remember exposure history causing fever or temperature more than, don't call it fever, call it as temperature more than 40 degrees Celsius or 104 Fahrenheit, causing neurological sequelae or organ failure. Organ failure, what all are there? ANS, coagulopathy, AKI. Okay, so this is one thing you can remember about definition of heat stroke. Is there a classification? Yes, probably it's one way to think about it. Is exertional or a non-exertional? So exertional is what I told you, rigorous physical activity, especially seen in soldiers, athletes, marathon runners, etc. Okay, these are the people who are prone to develop heat stroke. Okay, non-exertional are seen in patients with alcoholism, obese individuals. Okay, even with no physical activity, when they are exposed to some sort of heat atmosphere, they are also at a risk of developing heat stroke. So how do we manage heat stroke? Always remember, it starts with ABCs first. Start cooling the patient, look for organ failure, treat and prevent. Okay, that is what we go with management of heat stroke. So firstly, when you have higher temperature, altered mental status, evaluate the cause. Okay, you look at the history, and if these two are present, check your finger glucose test, rule out possibility of hypoglycemia causing altered mental status. Okay, look for electrolyte imbalances, do all your basic lab panels. Okay, always do cultures in these patients and look for intoxication as well. You need to rule out all of this And heat stroke becomes a diagnosis of exclusion when all the other things which I told you earlier is ruled out. Okay. So why do we do a blood panel and all of this? Patient is basically you need to rule out all of this, and then we come to a diagnosis of heat stroke based on ruling out criteria. So what is the first step? I told you ABC. After ABCs, it is cooling the patient. Cooling you can do by surface cooling or intravascular. You give the patient IV. Okay. So if the patient comes to your ER, if the ABCs are managed and the patient is still a little conscious oriented and able to maintain his airway, best possible thing is to immerse this patient in an ice bath if it is available. If you don't have it, use a body bag, put the patient in the bag, fill the bag with cold water, okay, and add some ice into it, whatever you have. If you don't have that also, probably it's better to cover this patient in multiple plastic sheets, and then add ice into that. Okay, it's like a wrap. Okay, like a burrito wrap which you see, right? It's something like that. That's why it's called as a tarp taco. Okay, so in this is one of the other ways you can do surface cooling. Okay, along with this, if you don't have any of this, try and put a lot of wet blankets on this patient, and use convective methods like putting a fan, etc., to reduce the temperature. Okay, so it is called as an evaporative type of cooling. So what are the types of cooling? If you've understood all of this, it can be categorized as conductive cooling and an evaporative cooling. Evaporative cooling, I told you, put a blanket, use fan or air blower to reduce the temperature. In conductive cooling, the ones which we talked about earlier. Okay, so it can be internal or surface. Surface is what I told you about: immersive ice baths, ice packs, cooling blankets. Okay, especially when you have ice packs, etc., they tell you have to keep it in the groin area, axillary area, nape of the neck, etc., wherein it will help in reducing the temperature at a faster pace. Internally, if you're trying to do conductive cooling, it is by cold crystalloids and intravascular balloon catheter system. Okay, these are things which require expertise. The best thing is practically what we can do is cold crystalloids. Okay, so how do we do the cold crystalloids? Numerous studies have been done wherein they use chilled crystalloid, that is a temperature between 0 to 4 degrees Celsius, to reduce the core body temperature roughly to around 1 degree centigrade per liter of crystalloid. Okay, so if you're giving it at a 30 to 40 ml per kg, it will cause around 2 degrees Celsius drop. Remember, for heat stroke, IV, if you're giving cold crystalloids, one, the temperature of the crystalloid should be between 0 to 4 degrees Celsius. What do? Usually, you can use your 30 to 40 ml per kg itself, okay, because you're going to reassess the patient the first 2 hours. Okay, the whole thing is in the first 2 to 3 hour period, you want to drop the temperature at least by 1 to 2 degrees Celsius, and by doing so with around 0 to 4 degrees Celsius of cold crystalloid, you can at least get a drop by 1 degree per liter of crystalloid. Okay, majorly along with this, better to use a multimodal, that is, do both evaporative cooling, conductive cooling. In conductive cooling, do internal cooling, surface cooling. Do whatever is possible, but always keep a watch on the temperature. Okay, that is what is the ultimate goal in heat stroke. Okay, like how we talked about oxygen therapy and carbon monoxide toxicity, each issue has its pillar of treatment, and pillar of treatment for heat stroke is cooling. Okay, so what do we do? When we do all of this, you need to monitor temperature. That is the most important target that we are having. Okay, so what the best way, okay, so is to use a esophageal probe or a bladder probe. Okay, to check the temperature when if it is available. Rectal temperature can also be monitored, but usually it has a lag time. Okay, so that is one thing you need to remember. Okay, what are the temperature goals? As I told you. Okay, so try and achieve the drop in temperature to roughly around 38 degrees Celsius within 1 to 2 hours, or as rapidly as possible. Okay, whenever it is there, it is always possible the patient can switch back to hypothermia as soon as you stop this. So you have to keep a watch this patient and always monitor to prevent any overshoot. Okay, overshoot can be two things. Once when you have stopped, it can go back to more than 40 degrees, or else if you have given too much of cooling, it can drop below 36 degrees. Okay, both are detrimental, so you have to be very careful and have a close monitoring. More close monitoring is only possible when you have an accurate system of monitoring for temperature. Okay, Always, whenever this is present, first 6 hours is what is mandatory to have temperature monitoring, but it's always better to have it up to 24 hours. Okay. So, what are the organ dysfunctions which we see in heat stroke? It can be rhabdomyolysis, hepatic failure. Okay. It can be as bad as requiring transplants. Okay. So, we have to be very careful when we are looking at patient can present with acute fulminant hepatic failure. Okay. Seizures, aspiration pneumonia, stress induced cardiomyopathy, arrhythmias, etc. These are the organ dysfunctions which are associated with heat stroke, along with coagulopathy, hypoglycemia, hyponatremia. Okay. So management is symptomatic care. Okay. So initially you have to monitor, closely monitor temperature, look for dyselectrolytemia, look for hypoglycemia, watch for coagulopathy, monitor GCS, rule out non-convulsive status epilepticus. Okay, neuroprotective measures, IV hydration. All of this is the supportive care that has to be looked into. And if at all any of these happens in the due time, if their patient is not responding, next subsequent care should be done as per routine principles for that particular organ failure. Okay. So prevention is very important. Okay, especially this is seen in marathon runners, etc., or patients who are in a closed atmosphere, obese patients, alcoholics, etc. Okay, and patients who are going to some sort of excessive cardiac activity. Nowadays there's high rocks, etc. Right, all of these things can cause hypothermia. So these patients have to be educated about hydration therapies. Okay, and whenever they are traveling, etc., probably they have to use light colored clothing, limit outdoor activities as much as possible, and use air conditioner whenever it's present. Okay. So few drugs can mimic this. Okay, especially like serotonin syndrome, hyperthyroidism, all of this can mimic this, like a heat stroke. Okay, so you need to be aware of these things. Okay, you need to ask the complete detailed history of the patient on what medications these patients are. If they're taking that, first rule out that is causing this, and then if it is there, probably these medicines have to be altered. So this is about heat stroke. Okay. Any questions until now? So, by and large, I have completed most of the topics related to basic trauma and toxicology. Okay, so the next important in trauma is what is your trauma-induced coagulopathy, hemorrhagic shock, damage control resuscitation, and MTP. Okay, that is what I'm going to deal with next. Any questions you guys have? Okay, Vishal has asked about, yeah, okay, he's mentioned it. Yes, hyperbaric oxygen therapy, correct. Practically, it's not available always. High flow oxygen is always good. Okay, it's always better as a modality for carbon monoxide toxicity. Okay.